back everyone. This is Dr. Chakravarti from Dr. Talks. Today we will be dealing with pneumonia. So first, what is a pneumonia? What is a pneumonia? Pneumonia literally means an infection of the lung parenchyma. There is multiplication of the microorganism within the lung alveoli, and there is some sort of host response to this multiplying organism, and that results in the exudative solidification of the lung parenchyma. That is what is called as pneumonia. So, how do you classify? Traditionally, pneumonia was classified into 4 groups, namely ventilator-associated pneumonia, or hospital-acquired pneumonia, and community-acquired pneumonia, or a healthcare-associated pneumonia. This traditional classification does not take into account the drug resistance, because classifying pneumonia and treating pneumonia, the most important thing to be noted is the drug resistance. The community-acquired pneumonia are usually caused by organisms which are not drug resistant, whereas the hospital-acquired pneumonia are caused by organisms which are drug resistant. That is the basic dictum. But we can classify patients into those with risk factor for drug resistance and those without risk factor for drug resistance. That will be a better classification, and that will help us treat the patient better and improve the treatment outcome. So, MDR patients, multi-drug resistant risk factors for MRSA and Pseudomonas. These are the 2 things you have to know. For Pseudomonas, it's basically a patient with a history of chronic bronchitis, or a patient with a history of COPD, patients with a history of bronchiectasis, history of cystic fibrosis, or a structural lung disease. They are more common to develop Pseudomonas. Whereas MRSA, it is more common in patients with recent history of antibiotic exposure within the past 3 months, hospital admission within the past 3 months, patients with underlying immunodeficiency, patients who have got a necrotizing cavity or necrotizing pneumonia, neutropenia, skin rashes, summer month, younger age group. These are community-acquired MRSA risk factors. Nosocomial MRSA risk factors can be a patient with immunosuppression, patient with chronic hemodialysis. These are the patients who are more prone to develop MRSA infection, and they should be treated with a drug-resistant protocol. So, what happens? What is the pathophysiology of pneumonia? The microbes. How does the microbe enter into the alveoli and cause pneumonia? Before it entry, there are certain host factors which will prevent the pneumonia. First will be the nasal hairs in the turbinate. This will trap the large air particles. First one. Second, the branching tracheobronchial tree will trap with its ciliated columnar epithelium will try to trap the other organism which escape the nose, and because of its mucociliary clearance will clear the organism, or because of its antibacterial property can even kill the organism. Thirdly, the cough reflex and the gag reflex will prevent the aspiration in a conscious patient. Fourthly, if the the normal microbiota of the respiratory epithelium will prevent the growth of infective organisms. These 4 are the main factors. If suppose an organism escape all these factors and enter into the alveoli, there we have the pulmonary macrophages. This pulmonary macrophages can phagocytose the organism and kill the organism. If they are not able to kill, they can clear the organism by either a lymphatic route or by the mucociliary clearance. Only when the ability to clear the organism is by the macrophage exceeds, or when there is a heavy microbial load, that is when the microbe will fail to clear and microbe will produce inflammatory mediators. These inflammatory mediators produced by the macrophages are named in the interleukin 1, TNF alpha, interleukin 8, GM-CSF. This is responsible for fever as well as the neutrophil infiltration. There will be peripheral neutrophil exists of the neutrophils in the periphery, as also this neutrophil will cause the damage to the alveolo-capillary membrane. By damaging the alveolo-capillary membrane, the neutrophils will first influx from the alveolo-capillary membrane first goes in the interstitium along with RBCs and proteinaceous fluid. Then it will later enter into the alveolar epithelium. From the RBCs, you will have RBCs, you will have the macro neutrophils will enter into the lung parenchyma, causing exudative solidification of the lung parenchyma. This is what is called as pneumonia. So this is one mechanism. The second mechanism will be the normal alveolar flora will prevent the growth of pathogenic microorganisms. When this flora is altered during an upper respiratory infection or during treatment with an antibiotics, this will result in the native pathogen overgrowing and causing pneumonia. So next is the pathology. What are the stages of pneumonia? The first stage is the stage of edema or congestion. So during this stage, there is a proteinaceous alveolar exudation which is rich with protein and microorganism. This stage of congestion is a transitory phase. This stage of congestion is changed by a stage of red hepatization. Red hepatization means there is RBC, there is microorganisms, there is neutrophils within the alveoli. This hepatization means the solidification, it resembles a liver consistency, so it is exudative solidification, red hepatization. Third phase will be the grey hepatization, where there won't be any RBCs, there won't be any RBCs or there won't be any bacteria, but there will be predominance of neutrophils and fibrin. Then there comes a stage of resolution, where macrophages become the predominant alveolar cell and it will clear the RBCs, macrophages and other organisms. This is the pathology. So, how do they present? Before going to the presentation, we will see the most common causative organisms. Causative organism, outpatient, inpatient, there is non-ICU and ICU setup. This is important because, as we already mentioned, the drug resistance will play a role in the causative organism. The outpatient cause of pneumonia are because of Streptococcus pneumoniae, Chlamydia pneumoniae, Mycoplasma pneumoniae, Haemophilus influenza and respiratory viruses. The respiratory viruses include influenza A, influenza B, parainfluenza, human metapneumovirus, adenovirus and respiratory syncytial virus. This is the OP type. The non-ICU type, the inpatient non-ICU type includes the same organism with an exception of a Legionella, Haemophilus influenza, Streptococcus pneumoniae, Chlamydia pneumoniae, Mycoplasma pneumoniae and Haemophilus influenza and Legionella pneumonia and viruses. The ICU has got a unique set of organisms, namely MRSA, Pseudomonas and Legionella. Along with it, gram-negative organisms can also cause with the usual pneumococci and H. influenza and viruses. These are the causative groups. Now, next one you have to present is the typical versus atypical. In typical, patient presents with the usual symptom. It is caused by the organisms like Streptococcus pneumoniae, Staphylococcus aureus, Klebsiella pneumoniae, and Pseudomonas. The atypical is caused by Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella. The basic difference is that typical organism will have fever, cough with expectoration, will have productive sputum. Atypical organism will have fever, but more of dry cough, more of breathlessness than the typical symptom. They will be more productive, there is more dry. Here there is more breathlessness and extrapulmonary manifestations are more common with the interstitial pattern, and they also have this, they don't have lobar pneumonia-like presentation, they have got a bronchopneumonia-like presentation, and also they respond well to the beta-lactam antibiotics like penicillins, whereas they respond better to azithromycins and fluoroquinolones. So there is a basic difference. So anaerobes. When does anaerobes cause pneumonia? Especially in case of a dental infection, aspiration in a stroke patient or an alcoholic patient or drug overdose patient, when there is an altered sensorium, aspiration from oral cavity into the lung causing pneumonia, abscess or an empyema, that spectrum. So what are the epidemiological risk factors? What are the epidemiological risk factors? Namely, first, if there is exposure to rabbit, think of Francisella tularensis. there is exposure to bat, think of Histoplasma capsulatum. If the patients have exposure to cat, goat, sheep, think of Coxella burnetii. If the patient has got exposure to any ship travel, or the patient is having fever, diarrhea, hyponatremia, raised CRP, think of Legionella pneumonia. If the patient is having bronchiectasis, think of Klebsiella, think of Burkholder capaciae, Pseudomonas, and Haemophilus influenza. These are the group organisms. If the patient is a chronic alcoholic, think of Klebsiella pneumonia and pneumococcal pneumonia. If the patient has got underlying lung abscess, it is predominantly because of anaerobes and the microaerobic streptococci. Then we will be dealing with the clinical features. The pneumonia, patient usually presents with fever, cough with the sputum. The serum is usually productive sputum. Sometimes there can be hemoptysis, there can be breathlessness. The patient can have pleuritic type of chest pain. The patient can have atypical symptoms, especially the elderly people. They can present with altered sensorium or GI manifestation like abdominal pain, nausea, vomiting. These symptoms are very common. Signs, there will be signs of consolidation. There will be increase in respiratory rate. There will be use of axillary muscles of respiration. There will be increase in heart rate. There will be there will be VFUR, the vocal feminine resonance will be increased. The patient can have dull note on percussion. The patient can have associated effusion presentation. It will have low air entry over the lung bases. It's called as parapneumonic effusion. These findings can be present. What are the cardiac complications? Pneumococcal infection is associated with increased platelet activation. There is more of procoagulant activity, so there is no inflammation. It increases the chance of ACS, it increases the chance of congestive cardiac failure and arrhythmia. So how do you investigate? Investigation, you can diagnose pneumonia by either clinical diagnosis and an investigation and the microbiology diagnosis. Clinical diagnosis, any patient with fever, cough, expectoration, and auscultative evidence of pneumonia consolidation, with an X-ray evidence of infiltration, you can clinically diagnose this as pneumonia. But the problem with the clinical diagnosis is that we have got a plenty of other differential diagnoses like acute bronchitis, acute exacerbation of chronic bronchitis, patients with pulmonary embolism, pulmonary edema, malignancy, hypersensitivity pneumonitis, radiation pneumonitis, multiple causes. X-rays can give certain some clues regarding the etiology. X-rays, if the patient is having, let's say, bulging interlobar fissure, you have to think of Klebsiella pneumonia. A patient having much more pneumatoceles, think of Staph aureus. A patient having upper lobe cavity, predominantly in India, almost always it is tuberculosis. These are the X-ray signs of etiology. The other investigations, the common investigation include, first we will say go for gram stain and cultural sensitivity. This is sputum cultural sensitivity. Gram stain can identify whether gram positive or gram negative. Gram positive bacteria like Streptococcus pneumoniae, Staph aureus, and a lot of other gram positive organisms, gram negative organisms can be picked up by gram staining alone. The cultural sensitivity can help identify the pathogenic organism. The yield of cultural sensitivity can be increased if you use bronchoalveolar lavage or if you improve the hydration by giving IV fluids. That will increase the yield of antibiotic culture report, and you can also get the antibiotic sensitivity based on the culture report. Then the other one is really blood culture. Blood culture is usually not useful. It is very useful in the case of chronic liver disease, patients with severe pneumonia, patients with asplenia, complement deficiencies. Only in these patients culture is significant. Another patient, the yield is very poor. Even if you identify, you are going to identify pneumococcal pneumonia, which is usually covered by all the empirical management, so there is not much use. Then, importance of markers. The two markers that are usually used are the procalcitonin and CRP. What is the use of procalcitonin? Procalcitonin can pick up bacterial infection. It can separate a bacterial infection from viral infection, and it can higher value indicates the need for antibiotic treatment, and a normal value means you have to stop the antibiotic treatment. It is very useful marker, and the CRP is indication of treatment failure. Both of them are acute phase reactant, which are increase in response to an acute infection. Then serology. Serology means a four-fold increase in the serum IgM titer between an acute and convalescent serum sample to the specific pathogen can clinch the diagnosis. It is usually useful in organisms like Coxiella burnetii, which can't be picked up by other tests. Then, urine antigen and PCR. PCR is usually done for viruses. All the respiratory viruses can be picked up by throat swab RT-PCR. The bacterials which can be picked up by RT-PCR are the atypical organism like Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella pneumoniae. They can be picked up by RT-PCR. The urinary antigen which are used to diagnose are the pneumococcal pneumonia and for the Legionella antigen. It has got very good sensitivity and specificity. Now, coming to the treatment. Before treatment, it is important to understand the two scores, the curve 65 score and the PSI score. The curve 65 score has got four components: confusion, urea more than 7 millimoles per liter, respiratory rate more than 30 beats per minute, blood pressure systolic less than 90 and diastolic less than 60, and 65 means more than 65 years of age. The score is 0. You can treat the patient OP. You need not go for admission because the 30-day mortality rate is very poor, very low. The scores of 1 and 2, usually we can admit in the wards. The mortality rate is not very significant. At the same time, you can you can advise the patient for an admission, hospital admission. OPD, wards, if it's more than 2 or 3, more than or equal to 3, you have to go for ICU as there is significant risk of mortality, 30-day mortality. Whereas PSI is based on multiple factors like age, comorbidities, the patient lab features. They are classified into 5 groups, and group A has got very poor mortality rate and is usually very difficult to calculate in an OP, in an emergency setting. So we go for curve 65 score. Now, which are the pneumonia which have high chance of going into severe pneumonia? We have certain clues. Suppose the patient's respiratory rate at admission is more than 30 breaths per minute, the SpO2 is less than 90%, or if the patient is having multilobular infarction, if the patient has a severe metabolic acidosis, pH of less than 7, pH is less than 7. If the patient is having a low platelet, low neutrophil count, low glucose, hypoglycemia, hyponatremia, or the patient has got a low albumin. These are risk factors for progression. Tachypnea, desaturation, multilobular infarction, acidosis with thrombocytopenia, neutropenia, hyperglycemia, hyponatremia, and hyperalbuminemia. The pneumonia patient with all these features, he has got high chance of going into respiratory failure, septic shock. So you have to treat the patient with ICU admissions. Now, coming into the antibiotic management, OP patients have to be managed into 2 groups. Those patients with healthy patient, no antibiotic in the past 30 days, go for an acitro or a doxy. Acitro 500 OD, doxy 100 mg PD. If the patient is IP, if the patient is OP and has received antibiotic within the past 30 days, then you can go for a respiratory fluoroquinolone like levofloxacin or amoxiclav group of drugs. This can be given under outpatient patient. If the patient is an inpatient in non-ICU, you can go for combination of zone 1 gram IV, 2 gram IV OD plus acitro 500 mg IV OD. This can be given as a usual protocol for non-ICU admissions. For ICU admission, the same zone plus acitro can be given. If the patient is having risk factor for MRSA, then you have to go for vancomycin or linezolid. Anything of the two should be used. If the patient is having risk factor for Pseudomonas, you have to use Piptaz or imipenem or meropenem. This should be combined with either a fluoroquinone, respiratory fluoroquinone like a levoflox or ciproflox, any fluoroquinone group, or aminoglycosides like an amikacin, gentamicin, this is group of drugs, or you have to go for in IV azithromycin. You can combine with any of these three agents. So this sums up the management of community pneumonia, outpatient therapy, azithromycin or doxycycline. If the patient is receiving antibiotic and has comorbidities, go for a respiratory fluoroquinolone and augmentin. If the patient is an inpatient, we have to go for zone plus azithromycin. If the patient is an ICU, we have to also start with zone azithro or taxim. Anything can be used. If your MRS is better, go for ranco or linezolid. If the patient has pseudomonas, go for peptaz plus levo or amikacin or azithro, any combination of these two. This sums up the treatment for pseudomonas. What are the other things you can do for this patient? You can use adjuncts. If the patient is hypoxic, you have to administer the oxygen. If the patient goes for respiratory failure, go for mechanical ventilation, and intubation mechanical ventilation should be given. If the patient has hypotension, you have to go for vasopressors. IV steroids is very useful. Methylprednisolone or prednisolone is useful in severe cases. And with the patient's failure to improve, you have to think of other diagnosis. Where the patient does not have a pneumonia, he can have a pulmonary edema. You have to think of other diagnosis, or the organism can be a drug-resistant organism, or the treatment you give will be of a low dose or a low duration or a low frequency. Something is abnormal that should be taken care of. What are the complications of pneumonia? The common complications include lung abscess, parapneumonic effusion, empyema. Patients can go for bronchiectasis. Once the pneumonia settles down, bronchiectasis. These are the common risk factors for common complications of pneumonia. What are the vaccines? You can give two vaccines, namely the pneumococcal vaccine and the influenza vaccine. Pneumococcal vaccine, two variants. The PCV13, the polysaccharide conjugate vaccine, where the polysaccharide capsule of 13 pneumococcal strains are taken. They are conjugated with the protein molecule to improve the T cell mediated immune response. So it will have a long-term immune memory. Second group is that there will be 23 polysaccharide capsules that will be taken, the PPSP23. It can be given in young patients or immunocompromised or elderly adults. In those patients, it can be given. Administration of vaccine has reduced the incidence of invasive pneumococcal infection, and it also has reduced the drug resistance in pneumococcal infections. So this sums up our discussion on community-acquired pneumonia. We will further have discussions on ventilator-associated pneumonia and lung abscess in the subsequent sessions. Thank you.